All right. I think most of us have arrived here, so we can probably get going. Can you hear me okay?
Yeah, you're good.
Okay, good deal. So I'm Xavier Almatine. I am one of Dr. Brittany Van Ness's co-residents. I like to think of myself as her friend as well. So Brittany and I were both fourth year residents. She completed her, or she's in the process of completing her psychiatry residency training at the University of Washington. She is in the Boise track, meaning that she completed her first couple of years of training in Seattle and is here in Boise finishing it up. Dr. Van Ness completed her undergraduate education at the University of Buffalo in Buffalo, New York. She received her bachelor's in biomedical science. She went on to receive her MD at the University of South Dakota, Sanford School of Medicine in 2020. Notably, Dr. Van Ness also was a foster parent during her residency training and was the foster parent to not one, not two, not three, but to four foster children. She's also a dog mother and has a Great Dane dog. So that that is Dr. Van Ness, and Dr. Van Ness, take it away. We're very excited to hear your Grand Rounds presentation.
Thank you so much for that introduction, Dr. Almatine. I appreciate it. Yeah, and thank you all for joining today. This is a topic that I'm really excited to discuss with you, and hope we have some time at the end to kind of open it up and hear about other people's thoughts. I also just wanted to thank Dr. Zaleski, who has provided me some guidance and support to put together this presentation. So we will jump right into it. See. So a couple objectives before we get started. So we will describe the goals and the important results of the Harvard study of adult development. And we will discuss the likely factors which influence the challenges in achieving this quote unquote good life. We are going to identify tools to help assist our patients with assessing and improving their own relationships. We will review the basic tenets of attachment theory. And then we are going to describe the WISER model and how it can be used to help patients troubleshoot difficult relationships. So before we jump into looking at some of the data regarding the impact of relationships on mental health, I wanted to take a moment to reflect on a patient case that will likely sound familiar to many of us. So I'll just go ahead and read through this case. So Sterling is a 64-year-old man presenting to your clinic with the chief complaint of feeling down lately. He is separated from his wife, retired, and has 3 adult children. Sterling says that he has not been feeling interested in anything lately, often feels tired, and hasn't reached out to his children for fear of being a burden. His mood is generally sad, and he has been crying more over the past few weeks. Sterling is diagnosed with major depressive disorder, started on an SSRI, and given resources for a therapist in his area. So now I'm going to actually read a more in-depth psychosocial history for Sterling. And while I read this, I would like you to reflect on how your feelings about Sterling's case change. Consider if Sterling's early life has impacted his attachment to others. How much does Sterling's lack of close relationships as an adult maybe impact his overall mental health? And what could be some of the focuses of psychotherapy if you were working with Sterling? So Sterling was born at home with the help of his 12-year-old sister, Rosalie, in 1923. He was one of 5 children in a stressful household ran by his father. Sterling's father worked as a steel worker, however, only brought home a fraction of his wages due to struggling with gambling. This forced the older children to have jobs in order to support the family. When Sterling was only 3 weeks old, his father committed his mother to a sanitarium, leaving Rosalie to become Sterling's primary caregiver. Sterling's mother did eventually return home, however, was unable to care for the children. And by the time Sterling was 9, his mother was sent back to the sanitarium, this time permanently, and his father abruptly moved away, leaving the children to fend for themselves. A family friend named Harriet agreed to take in Sterling as her own son had died in a tragic accident. And this turned out to be a very positive experience for Sterling, as his adoptive parents were supportive and stable. He was able to do well in high school and was accepted to Harvard with a scholarship. Sterling graduated college in 1944 and then served in the Navy during World War II. After the war, he married, had 3 children, and had a successful career as a materials scientist. So if we fast forward to Sterling at the age of 64, he has recently retired and is currently living alone in a trailer in rural Montana. Though Sterling never officially divorced his wife, they have been separated for over 15 years. His children are grown, and though he loves them very much, he does not often see or talk to them. Sterling cannot identify any friends except for an 87-year-old woman who lives in a nearby trailer, who he sometimes socializes with in the evenings. Sterling doesn't know if his older sister Rosalie is still alive and hasn't been in contact with her for many years. So this is a patient that is based on the Harvard study of adult development. So these are true facts about his life that were collected from the age of 19 when Sterling joined the study. So this study began in 1938 with the ultimate goal to understand what it is that make people thrive. And though many longitudinal studies have retention rates between 30 to 70%, the Harvard study of adult development actually had a retention rate of 84% of their original participants. They also continued to expand the study to include over 1,300 descendants of the original population, which allows for at least more diversity given that first initial population all identified as male. So of the original 724 participants, 268 of them were recruited from Harvard. And this included men like Sterling, who they quote unquote deemed likely to grow into healthy and well-adjusted men. As you can imagine, many of these men were from well-off families. However, there were some like Sterling who came from more disadvantaged backgrounds on scholarship. And actually 13% of these men had parents who had immigrated to the US. And the remainder of the study population was recruited from inner city Boston. And as you can imagine, many of these participants grew up in troubled families and in disadvantaged neighborhoods. In this group, about 60% had at least one parent that had immigrated to the US. So in order to understand what makes people thrive, the study set out to collect data on these men in a variety of different categories. So they obtained detailed health histories, which included data on numerous health factors such as weight, amount of exercise, substance use, surgical history. They also asked about employment, friendships, hobbies, spiritual beliefs, and political preferences. As the study progressed, it included questions that kind of went deeper than just simple data collection and started asking a little bit of harder questions. Some examples of these were job and marital satisfaction, childhood memories, methods of resolving conflicts, low points in life, and sources of worry. So the study collected this data in a variety of different formats. This included questionnaires that the participants completed every 2 years, as well as complete health records from their doctors every 5 years. And then they would do in-person interviews with all of the study participants every 15 years.
Thank you.
I'm gonna go downstairs so I can watch the video.
Okay.
So earlier this year,
I'm just listening to it right now.
the current director and associate director of the study actually published a book titled The Good Life, Lessons from the World's Longest Scientific Study of Happiness, which was an inspiration for this talk. So the director is Dr. Waldinger, who is a psychiatrist that teaches at Harvard Medical School, and then Dr. Schultz is a psychotherapist. So there's many interesting points of this book and highly recommend it as a read if you're interested. But I think this quote really sums it up. So they stated that for 84 years and counting, the Harvard study has tracked the same individuals, asking thousands of questions and taking hundreds of measurements to find out what really keeps people healthy and happy. And through all of the years of studying these lives, one crucial factor stands out for the consistency and power of its ties to physical health, mental health, and longevity. And no surprise, that was good relationships. I realize this may seem like an obvious summary that didn't necessarily need 84 years of data to back it up, but I also encourage you to think about how much this is taken into consideration when we think about our patients. So I think it's also important to take some time to consider why this quote unquote good life is challenging to achieve. And Dr. Waldinger and Schultz bring up a couple of different hypotheses for why this may be. So the first is regarding the impact of culture on individual well-being. They state that the good life may be a central concern for most people, but it is not the central concern of most modern societies. Life today is a haze of competing social, political, and cultural priorities, some of which have very little to do with improving people's lives. The modern world prioritizes many things ahead of the lived experience of human beings. So we'll take a brief intermission here to read this quote that I really enjoy from David Foster Wallace. So I'll give you a minute to do that. So obviously a fun example of, this aspect of culture that, we assume is all really, we're really aware of all the ways that culture impacts and leads our lives, but really that may not actually be the case. So the author has also brought up this concept of effective forecasting as a barrier of reaching the good life. So this is a psychological term that refers to essentially how we think we will feel in the future. And as humans, we are constantly making predictions about how all kinds of things in our lives, both big things and small things, like will make us feel in the future. Unfortunately, research on affective forecasting indicates that we're actually pretty bad at it. And this also includes our predictions about how beneficial relationships will be for our well-being and happiness. This is not only applies to relationships with like close relationships, but also even just with our interactions with strangers. Which ties into this really interesting study that was published in the Journal of Experimental Psychology in 2014, titled Mistakenly Seeking Solitude, by some researchers at the University of Chicago. And they asked this question that if humans are a social species, then why do strangers routinely ignore each other? And they hypothesized that either solitude is a more positive experience than interacting with strangers, or people misunderstand the consequences of distant social connections. So this study included quite a few different experiments, so we're just going to look at a couple of them. So the first is experiment 1A, and this included 118 morning train commuters. This is in Chicago, and they were randomly assigned to one of three groups. So there was a connection group, a solitude group, or a control group. And so essentially they were just instructed if they were in the connection group that they would, on their morning train ride, have a conversation with a stranger. For solitude group, they were asked to just keep to themselves and not have a conversation. And then there was a control group who were told basically just do whatever you normally do on your morning commute. And they asked everyone to complete a survey and then some like personality inventories at the end of the train ride, and to mail them back to the study. And they asked for ratings of overall pleasantness of their commute, levels of happiness or sadness after their commute, and then levels of productivity during the commute. And then the connection group was also asked some questions about the conversation that they had with a stranger. So we'll get into the results shortly here, but there was a kind of a second piece for experiment 1, and that's experiment 1B. And they had 105 commuters that were recruited at the same train station that they used in the first part of the experiment. And in this part of the experiment, they essentially just asked people to imagine they were asked to do one of the groups. So to imagine they were in the control group, the connection group, or the solitude group, and then to complete the surveys based on what they anticipate their responses would be if they were asked to do those things. So these are the results from the experiment 1A and 1B. And so if we look at the graph on the left-hand side, this is looking at the rankings of how positive an experiment was or was predicted to be. So interestingly, we can see in the darkest columns there that this is the connection group, and for the predicted group, they rank this as being significantly, the least positive experience that they would have had as compared to the other groups. However, this is actually the complete opposite of what the actual results of the connection group was, which was actually the most positive. And these results were even controlled when they looked at like levels of extroversion versus introversion. And then for productivity, assuming that people use their train ride for being productive, the graph on the right shows that the commuters predicted that being in the connection group would lead to low levels of productivity, during their train ride. However, again, this is not what the actual outcome was of the connection group, who reported essentially unchanged levels of productivity. So we're going to skip ahead to experiment 3A and B. Experiment 2A and B was the same protocol as 1A and B, but just took place on city buses instead of trains. And the results were consistent with the results of 1A and B. So for 3A and B, the study asked the question, if connecting with strangers is truly more pleasurable than sitting in isolation, then why do people not learn from this and then behave differently? They hypothesized that there is some kind of social norms that discourage connecting with strangers. One of these includes a concept referred to as pluralistic ignorance, which can be defined as a phenomenon in which people mistakenly believe that others predominantly hold an opinion that's different from their own. So in this case, there may be this belief that assumes that even though they're interested in connecting, they assume other people are going to be less interested in connecting. So for experiment 3A, the train commuters were asked to imagine being part of a connection group and completed a survey. And so they, again, we're just asked to imagine, not to actually do it. And they were supposed to rate how interested they would be in talking to somebody else, how interested they thought someone else would be in talking to them. They were rating how difficult it would be to start a conversation with a stranger, and then to give a percentage of how willing other people would be in talking to them. And 3B was the same as 3A, just on a bus. So over 100 participants completed either one of the two surveys between the 3A and 3B. And this data revealed that participants reported being significantly more interested in talking to others than they thought others would be in talking to them. They predicted that less than 47 of other commuters would be even willing to engage in a conversation, and that it would be relatively hard to start. So yeah, from this study, this really suggests that the commuters, even though it was a positive experience when connecting with others, there's also this level of people being concerned that there's this meaningful risk of having social rejection. And this is one of the ideas behind the results that came up in experiment 1A and 1B. So returning back to our discussion of what makes this good life so hard to achieve, we can also consider this concept of a happiness set point. So there's a psychologist and researcher, Sonia Lombovsky, who studies what makes people happy and specifically has examined the degree to which our level of happiness is changeable. So previous research has indicated that people have this so-called happiness set point that is influenced largely by just genetics and personality traits. And generally speaking, it is thought that even after something happens to make us feel happier or sadder, we return to a general level of happiness that we've always felt. So even with a happiness set point determining 50% of our happiness, there is still thought to be around 40% that can be accounted for just based on our intentional activity, so our actions and choices. So if we combine these concepts, that relationships are at the center of a good life and that 40% of our happiness is based on our intentional activity, this can help guide how we help patients achieve their goals of well-being. So we commonly educate patients on the role of exercising, eating a healthy diet, and avoiding substances in order to achieve a healthier life. But how often do we really spend time talking to patients about how their relationships are directly influencing their well-being? So Dr. Waldinger and Schultz present this concept of a social universe kind of as a starting place to help assess frequency and quality of relationships. So the first step is to identify a list of close relationships, which may include both friends and family, but also just people that, get you frequently interact with, which could be like colleagues, or other people like that. Um, and then the next step is to ask yourself how a relationship makes you feel and how frequent are your interactions, and then plot those here on this graph. So here's an example of what a graph could look like. And once you have the map of the social universe, then you can ask a few questions to help guide how this, like how to approach these relationships. So questions to ask could be, why is this person in that particular place? And what is it about the relationship that compelled them to put you there? And is this relationship where you want it to be? Um, if a relationship is particularly difficult and has been giving you a depleted feeling, are there any specific reasons for this to come to mind? So after reflecting on the initial placement of your relationships, um, you can identify a more ideal spot for where you would like the relationship to be. So perhaps you're wanting to see your mom more frequently and to deepen your connection. Maybe you have relationships that are depleting, but they're also important to you and maybe require more attention. The summary of creating a social universe is to cultivate gratitude for all of our relationships and to acknowledge that every relationship is an opportunity for deeper growth and connection. So, when helping patients to assess their relationships, it is also important to consider the type of support that any given relationship can provide. Humans are often referred to as social creatures, but what does that really mean? When we say that humans are social creatures, we're essentially saying that each of us as individuals cannot provide everything we need for ourselves. And the process of giving and receiving support is a foundation for relationships and in cultivating a meaningful life. So one way to assess the nature of relationships is to identify which categories any given relationship falls into. So it's important to note that no relationship will be able to offer every one of these types of support. However, it can be helpful to take stock of where there is support and where support may be lacking. And so the authors of The Good Life have identified these 7 different categories as sort of the types of different support we need as humans. So the first category includes one of our most basic needs as living creatures, and that's safety and security. So I've provided some examples of the questions that the Harvard study would ask its participants over the years that fall into these different categories. So when identifying relationships that provide safety and support, the study asked questions such as, who would you call if you woke up scared in the middle of the night, as well as who would you turn to in a moment of crisis? So the next category is learning and growth, and they would ask questions such as, who encourages you to try new things, to take chances, and to pursue your life's goals? For emotional closeness and confiding, they ask questions like, who knows everything or most things about you? Who can you call on when you're feeling low and be honest with them about how you're feeling? And who can you ask for advice and trust what they say? For identity affirmation and shared experience, is there someone in your life who has shared many experiences with you and who helps strengthen your sense of who you are and where you've come from? In romantic intimacy, so do you feel satisfied with the amount of romantic intimacy in your life? Are you satisfied in your sexual relationships? For the help category, which includes both informational and practical help, who would you turn to if you needed some expertise or needed help solving a practical problem? Maybe you want to plant a tree or fix your Wi-Fi connection. Maybe you want to apply for health insurance and don't know how to do that. And last but not least, the fun and relaxation category. Who makes you laugh? Who do you call to see a movie or go on a road trip with? Who makes you feel relaxed, connected, at ease? So no presentation about relationships would be complete without a discussion of attachment theory. I believe many of us are probably familiar with John Bowlby's research on attachment theory. But we can review some of the basic tenets. So attachment theory is based on the evolutionary concept that in order to make it to reproductive years, infants and children need protection from some kind of attachment figure. And therefore, the system is designed to promote survival between maintaining proximity between children and the caregiver, particularly when a child is experiencing distress. And based on those experiences with attachment figures, this then affects how people think, feel, and behave in close relationships throughout their lifespan. As people develop over time, they build a mental record of their attachment experiences. And this can be broken down into two models. The first is a model of others, which includes if they feel others are reliable to provide safety and comfort. And the second is a model of self, which includes information about someone's ability to obtain safety and comfort, as well as if they feel worthy of those relationships. So a paper published in 2017 describes the concept of attachment insecurity as a diathesis capable of generating maladaptive responses to certain stressful or threatening events. So the model describes 3 types of negative events which can elicit distress in virtually all people, no matter what their specific attachment style is. So the first is negative external events, such as dangerous or threatening situations. The second is negative relational events, such as relationship conflict, separation, or abandonment. And the third is cognitive or emotional stressors, such as ruminations about negative events. So distress will then trigger attachment motivations, such as seeking proximity, support, or reassurance from attachment figures. Most people do have these experiences, even if they don't consciously feel or act on those motivations. So those attachment motivations will then lead to specific attachment behaviors that will mitigate and regulate distress, as well as the perceptions of the partner and the current situation. However, these behaviors and perceptions are dependent on what that person's attachment working model is. So perceptions of the partner in the situation will also be affected by how the partner behaves in the situation. So these enacted behaviors and perceptions will then affect the personal and relational well-being that individuals will feel, report, or display in this stressful situation. So the attachment working models essentially will impact all of these different stages. So it'll impact the distress, the attachment motivations, the attachment behavior, the perceptions of the partner, as well as how their partner behaves, and ultimately their well-being. So for individuals with a high degree of anxiety involved in their attachment working model, they tend to know when they are upset and will seek immediate assistance from their partners. They're motivated to reduce their distress by doing whatever they need to do in order to seek proximity to their partner. And this whole process is further exacerbated by their tendency to use emotion focused and hyperactivating coping strategies, which will divert their attention away from how to resolve the stressor and will ultimately keep their attachment system activated. Partners of anxious individuals may tire of continually providing reassurance and support, which the anxious individual may actually end up perceiving as rejection. Anxious individuals may also underestimate the level of care their partner has provided in the past and is willing to provide in the future. And all of these negative perceptions will generate less personal and relational well-being following any kind of stressful event. So when involved in stressful experiences, those with high levels of avoidance involved in their attachment working model may not know they're upset and may and will generally not seek support from their partner. They may attempt to reduce their distress by being self-reliant, which allows them to sort of reestablish their independence, autonomy, and personal control. These individuals will use avoidant and deactivating coping strategies, which is a defense that suppresses their conscious awareness of their distress and their attachment needs. So avoidant individuals may permit some contact with their partner, though this is generally on their terms and at an emotionally comfortable distance. And these negative perceptions will again result in less personal and relational well-being after experiencing stressful events. So secure individuals can recognize that they're upset during stressful experiences. Depending on the stressor and the skills that they have to deal with it, they may or may not seek support from their partner, though they are generally motivated to manage their distress by drawing closer to their partner, both physically and emotionally, though their experience is also facilitated by their use of using problem-focused coping strategies. So this allows them to resolve problems constructively with an appropriate level of assistance from their partners. Highly secure individuals are able to seek proximity, comfort, and support from their partners, which leads to a reduction of distress and allows them to pursue other life tasks. A secure partner will respond in positive and constructive ways, and the sum of these positive perceptions should lead to better personal and relational well-being following a stressful event. So many difficulties in relationships stem from these more insecure attachment models. And one tool that we can use to help our patients respond in a more productive way to emotionally challenging situations is called the WISER model. And the goal of this model is to try to slow down from automatic responses and behaviors to stressful experiences in order to attempt to utilize more secure or healthy coping skills. So the first stage of the WISER model is watch. And the goal of this stage is to cultivate a purposeful curiosity about the situation that is unfolding. So watch is referring to the entire situation, including the environment, the person you're interacting with, and your own emotions. So there's a few important questions that can be considered in this stage. We can ask things like, is this situation unusual or common? How does this situation play out? What typically ends up happening next? And what have I not considered that might be an important part of what is unfolding? So the next stage is interpret. In this stage, the goal is to fill in the blanks of why things are happening and what it means for us. So often this is the stage in which things start to go wrong and we make assumptions. The important thing in the interpret stage is to expand our understanding beyond just our initial automatic perceptions and try to consider other perspectives, even if that's uncomfortable. So questions to ask in this stage include, why am I feeling this way? What are these emotions that are coming up? And where are they coming from? What is really at stake? And what is so challenging for me about this situation? So then we'll move on to the select stage. So here we want to look at the options. And again, we want to try to move from a fully automatic response to something that's more considered and purposeful, that aligns with who you are and what you want to accomplish. So questions to ask include identifying what it is you want to accomplish and how you can best accomplish that specific goal. It can be helpful to identify if you have strengths that could help you, such as humor and the ability to take the edge off heated conversations, or perhaps weaknesses that could hurt you, such as a tendency to snap when criticized. So here we want to reflect on what would be a good outcome of the situation. Asking yourself, what is the likelihood that things will go well if I respond this way instead of that way? So stage 4 is when the plan of addressing the situation or conflict is carried out. And this can be helpful to practice the response and try to take realistic steps towards making it happen. And we want to try to evaluate the progress of the intervention as it's occurring and adjust the course if needed. So the final stage of the WISER model is to reflect. This is one of the most important stages to help shape future actions. So questions to ask include, how did that work out? Did I make things better or worse? And have I learned something new about the challenges I'm facing and about the best response? So now that we have, basic understanding of these 5 different stages of the WISER model, we can go through an example. Full disclosure, I just want to note that this example is 100% hypothetical. So I want you to imagine you're a psychiatry resident and you're working in a busy outpatient clinic, and a patient comes into you for an initial evaluation. The patient describes numerous psychiatric symptoms that they would like addressed, and then they state that they're concerned they have ADHD and they would like to be evaluated for this. So the watch stage has already begun as we notice some of these emotions that are coming up at this specific request. The resident takes a moment to notice that they're feeling some emotions, are feeling maybe some irritation, annoyance, dread, that they have to address this today with the patient. The resident mindfully notes their experience and acknowledges that they have been having this response more often lately at the request for ADHD evaluations. They start to ask themselves some questions. Why is this the response I'm having to the situation? The resident also takes a moment to observe their patient and try to consider what their experience may be. Perhaps they saw this on TikTok. Maybe they borrowed some friends' Adderall and thought it was really helpful. Or maybe they've just been struggling with profound ADHD symptoms through their entire life and have never been able to get appropriate treatment for their condition. So now it's time to move on to the interpret stage. So the resident acknowledges that they have already made numerous assumptions about the situation, which could impact their ability to see the situation clearly. They note that their initial thoughts included a concern that perhaps the patient was simply seeking a specific medication treatment, and they likely don't have a DSM-5 text revision diagnosis of ADHD. They reflect that they have experienced this situation in the past, which has led to negative patient interactions, and they fear that this is where the visit is headed. The resident wonders if the irritation they are experiencing is a manifestation of the concern that they're not competent in making this diagnosis in this setting, and they worry that no matter what the final outcome is, what their attending's opinion will be of their diagnosis and treatment plan. So it's time for the resident to consider their options on how to reflect, how to address the requests for this ADHD evaluation. So they reflect that their goal is to accomplish an accurate diagnosis while also trying to preserve their relationship with the patient. So they consider their options, given they don't have time to complete the assessment accurately with the remaining time left in the appointment. They consider explaining to the patient that due to the other psychiatric symptoms they have been experiencing, that there wouldn't be a way to accurately diagnose ADHD, and therefore the assessment will need to wait until some of their other symptoms are better managed. They consider maybe they should send the patient home with an assessment packet to complete, which would include a more in-depth history of their attention symptoms and have an assessment that their family and friends could fill out to try to give them a more accurate understanding of what's been going on. The resident also considers that maybe they should just refer the patient for psychological testing in order to figure out the appropriate diagnosis. So the resident is running out of time and needs to make a decision. They decide to discuss with the patient that though it is possible they have ADHD, it would be difficult to accurately diagnose given the severity of their other psychological symptoms. The resident expresses that they understand the patient's difficulty with focus is impacting their ability to function at their job, and they really want to work with them to continue to treat their symptoms. So the patient responds in an angry tone that they clearly don't care about them if they aren't going to give them the medication they're in need of, and they're just going to plan to seek care elsewhere. So now we move on to the reflection stage, really the most important of this whole process. And the resident reflects that though this was a really challenging patient encounter, it was also an opportunity for growth for their future patient visits. They think about their need to continue to build their knowledge base for accurately diagnosing ADHD in adults and seeks out additional supervision. The resident's also able to reflect their experiences with their colleagues to get additional viewpoints on what others might do in that situation. The resident reflects that there isn't always a right way to do things and acknowledges that though this may be a weaker point in their skill set, they do have strengths in other aspects of their job. So now let's reflect on the questions that we brought up earlier in the presentation regarding our patient Sterling. Though we can only make hypotheses about these responses, I think it can be helpful to think through specifically concerning his report struggling with, severe depression. Given his difficult childhood with his, parental figures that were not always present, I do wonder if Sterling would generally follow that avoidant working model of attachment. And though he did have some positive relationships with his sister, Rosalie, and his adopted mother, Harriet, as as an adult, he hasn't really been able to keep any close relationships. And it's hard to imagine that this hasn't contributed to Sterling's overall feelings of depression, particularly now that he's retired and doesn't have as many social interactions. And as far as psychotherapy, could certainly be something that is just discussed with Sterling to try to figure out ways to give him a more robust relationships and areas of support in his life to help treat his depression. So, couple summary points. Consider prioritizing time asking patients about their relationships. Remember that people are generally not very good at knowing what makes them happy, and sometimes it can be helpful to tell patients that. Consider using a structured approach when taking a social history, so using things like the social universe or trying to go through those each different categories of the specific types of support that people need. And then consider even making having patients have increased social interaction as part of their overall treatment plan. And then remember that attachment working models may get in the way of experiencing meaningful relationships, and we can use the WISER model to help patients work through some of those difficult emotional experiences.